Dr. Kalra is a leader in endocrinology here in India, and she's currently a professor and consultant endocrinologist at Ramaya Medical College in Bangalore. And her interests lie in thyroid disorders as well as gender dysphoria. She's a member of many different endocrine societies, both in India and internationally, and she'll now describe some of the similarities and differences between the international and national standards of care.
So thanks, Dr. Priya. And at the outset, I thank ATHI, and I also thank Dr. Sanjay Sharma and Dr. Sanjay Kalra for giving me the opportunity to be at this forum, because I understand that all the experts are here and we can have lots of discussion on what type of best care we can provide to our transgender patients. So Dr. Hamnick's talk was very interesting because they are nearly doing what we are also doing in India. It's not much different what I understood, but still there are few differences in Indian care as compared to the international care. Not that we don't want to follow the guidelines. The things are, there may be a lot of issues like the patients may not be able to afford, and there may be a lot of other issues like social issues as well, because of which our care is a little bit different, but it's almost the same, I would say. The first and foremost, which I would like to put forth is like the major difficulty in our country is the pubertal arrest, which we don't do most of the times. Because what happens, most of the patients which I've been seeing, I've been taking care of transgender population since 2008. And what I've seen is most of these clients who come to me are around 25 years plus. And the reason they come to me late is because when they are young and they are dependent on their parents or families, they don't support them. They tell them that we can't support you for this, so we can't do anything. So only when they start earning, then they know, yeah, now is the time when we can go and take help. So by the time they have come to us, or they come to us, they are already post-pubertal, they are 25 years plus. I have clients coming to me first time at the age of 50, 55. Last client who came to me was 60 years actually. First time they have come to me and they want help. So there are a lot of issues regarding that. Then obviously I'll be discussing few of the therapy issues which we have. And the major thing which we face in our country is the family support. What we see in our country is the family support is lacking for many of my clients. We try to collate the data of around 150 patients whom we are having in our data log. And what we try to see the family support system. And we found that the family support is not good at all. So what is happening is once they try to go for the gender-affirming therapy or for the surgery, or they decide to change their gender, the family is not ready to support them because they say that the other family members may not be okay with that and we'll have social outcast. So they don't want to. And obviously, because of the cost therapy, sometimes we have to go for some cheaper alternatives as well. But what I understood is the same thing is happening in US as well. So when we are talking about the arresting of puberty, now we are clearly knowing this, that GnRH agonist can be given. But the problem is what happens by the time the patient comes to us, as I told, they're already 25 plus and they are already post-pubertal, and that's the time when they want the treatment to be started. And also the practice of giving GnRH, even if they contact us, is not very clear in India because we are not still very clear what exactly we should do. Because I have talked to many of my colleagues who are taking care of gender dysphoria patient or who are doing transgender care. And most of them are not very comfortable in doing this because we have lots of issues, parents come into picture. And sometimes we had problems with the doctor also, because what happens, the doctor may start the treatment, the parents may feel that the doctor did not tell the proper thing, and a lot of issues happen. So that's why we normally try to treat adults like above 18. Below 18, we hardly get few clients. I have few clients with me who are below 18, but their parents are not ready to sign any consent and they are not ready. So the child wants the treatment, but the parents are not ready. So I cannot give therapy to them. So this is one practice which is very difficult in our country at the moment. And I see a lot of these clients who are brought to me for making them understand not to go for it. So they're not brought to me by the parents to make them, to give them the GnRH agonist or suppress the puberty, but they are brought to me so that I explain them and I tell them not to go for it. So this is how I am seeing those clients. And I have not been able to start the therapy in any of them because of the lack of the parental consent, which is not happening. Now, as you also said that you are using oral tablets for estrogen, we are also almost doing the same thing. Transdermal estrogen we are not getting in India, so we are not using it, but we are mostly using oral only. In between, we were getting injectables, and some of our patients were happy to take injectable estradiol preparations, but for now, we are not getting it, especially in Bangalore, we are not getting it. We are using oral therapies, and we also start with a lower dose, 2 mg, and we slowly escalate. But here I would like to add something which is indigenous to our country. What's happening is, like, I write the 2 mg dose. As the patients want a faster effect, they go and procure double the dose. And they start with 4 mg or 6 mg at the outset without informing me. And then I get a call from the mother or the father that my child is taking a higher dose, because some of the parents also call me. I recently had a client who was around 20, who's around 26, and she came to me, and I started her on 2 mg. And what she did was she went and she bought 2 mg tablets, but she started taking 3 tablets every day. And the mother noticed that she is taking an overdose, because in India, it's not so strict to get the medicines just as per the prescription. They can get extra, and they can procure from 2 different pharmacies, and though nobody will come to know. So that's what she did. And she started taking 6 mg at the beginning itself. So which is obviously not right, and she can get a lot of complications. And then the mother, I got a panic call from the mother in about 2 days back. And then I called the client and I explained it to her that this is not to be done. I don't know how successful I was, but I'm trying to help them out. So this is how the problems arise in our country. And the same thing happens for testosterone therapy as well, because I have seen lots of my clients taking the therapy too frequently, and then they come with very high hematocrit values. And then I tell them, no, this is not right. You should not do that. So I try to explain them at the beginning when they come to me on day one. But still, these type of problems are there. The other major problem which is there in our country is the insurance coverage. There is no insurance coverage for any of these clients, either for psychiatric or endocrine or surgical care. So what happens, suppose I have a client who is on therapy, and suppose they get a side effect secondary to the therapy, they won't get an insurance coverage. They have to pay out of their pocket, because the insurance will say this was a cosmetic thing, they call it, you are taking, and we are not going to cover it. So this is one of the reasons which is leading to a major lapse. So what we are doing at our center, because we have a very good team who are trying to help transgender population. So what we do is we have some projects running. So we try to at least do their follow-up investigations with that money, because I would say 60% of my clients don't come for a regular follow-up if we don't arrange the tests for them. So I try to arrange the tests for them through hospital or through some projects, and that's how we are helping them out to do the follow-ups, because we know that some of the things at least should be checked. Many a times we are not even able to do prolactin regularly. Many things we cannot do regularly, but at least we try to do the basic workup so that we monitor them for side effects. So this is one major issue, because out-of-pocket treatment is the only way for them. And that's one deterrent for them to follow up regularly. And some of my clients would come today and then they will not come for 2 years because they won't have money to come. So this is one issue which we face in our country quite a lot. And as you also told that GnRH agonists are not taken by many of your clients as well, then the same thing is true for our population as well, because the cost for this therapy is higher. As I told, many of my clients are not having a family support. They are doing jobs. I have clients ranging from who are doing very menial jobs to ones who are engineers or even doctors, and they can afford everything. But there are clients who cannot afford. So some of them cannot afford the GnRH agonist, and many of them, I would say, cannot afford. And then we are giving them mostly spironolactone, and some of them are also on 5-alpha reductase inhibitors as well. And when we talk about the menstruation, which happens in trans men in between, when we give the testosterone therapy, we mostly end up using the depomedroxyprogesterone to stop that, because GnRH they are not able to afford, which we would want to give when they have that in between spottings or bleeding. So these are some of the things which we are facing in our population. But what I have seen in the past 12 years of my practice with gender dysphoria patients is that over a period of time, things are changing. One thing I have seen a positive attitude happening in India is the parents have become more supportive. Now, more and more parents are coming forth with the client, and they're trying to take the thing forward, and they're trying to help them out. And if I compare today's data of my patients as compared to 12 years back, what I have seen is the family support has increased. That's one thing. social acceptance has increased. Even in companies, they are hiring. And we have our transgender was one of the first in Karnataka to get the driving license for transgender, because initially they were not even giving driving license as transgender. But we have our first transgender who got the driving license in Karnataka with a transgender written on that. So that was one thing which we could achieve by forcing the government to help them, because we are trying to do that also, because if the government understands, then they can pester the insurance companies to include this also as one of the things of care in their list, which hasn't happened at the moment. And the other thing which we are also facing is admissions, because what happened that one of my clients was studying in a college and the principal refused to give the admission in the next class, because the principal said, now you have changed your gender and you don't have the certificate, because changing of the certificates, Aadhaar card, all these cards in India take a little bit of a longer time, and especially because of COVID, it wasn't happening so fast. And the client actually had to wait for 6 months to get admission. And then I had to talk to the principal, explain what exactly is happening. And then finally it happened. So we are all trying to help them out. And what we also practice in India is a team approach. We have a good team of a psychiatrist. I'm there, and we have urologists, and we have gynecologists, plastic surgeons who are all there as a team. And we practice as a team, and we take care of the transgender population who comes to us. So with this, I think this is what is the difference in the care we have as compared to you, but I think it's almost the same what we are doing. Yeah, thank you.